welcome to this webinar session organized by the Association of Future African Neurosurgeons. So I am Zolo Ivan. I am the president of the Association of Future African Neurosurgeons. It's a pleasure to have you all here today. I'm also a final year medical student from the University of Buea in Cameroon. So before we move to our presentation, which is going to be given by Dawin SICHIMBA, we are going to introduce our panelists. So, hello, Celestin. Please, can you unmute yourself and introduce yourself?
Okay. Hello, everyone. I'm Celestin Bilong, medical student from Cameroon.
All right, welcome, Celestin. Next is you're going to ask Dale. Please, Dale, can you unmute yourself and present yourself?
Okay. Hello, everyone. I am David Ulrich Dale, a first-year medical student in Russia. I am equally the head of communication department of AFAN. Thank you.
Thank you. Next is Joan Anito. Please, can you unmute yourself and present yourself, please?
Hello everyone. Yes, I'm Joanita Juma from Mombasa. I'm a medical officer. Nice to meet you all.
Thank you. Okay, next is Dr. Marvin. Dr. Marvin, can you unmute yourself and present yourself?
Yeah, hi everyone. I'm Marvin Topmany, year 2 neurosurgery resident in Ivory Coast.
Thank you.
Pleasure being with you guys.
Thank you. Thank you. Next is Nelson Mandela, please. Mandela, please, can you present yourself?
Evening for everyone. I am Sambre Mandela Nelson, student of level 5, Faculty of Medicine and Biomedical Science, Cameroon.
Thank you. Okay, next is Ezekiel. Please, Ezekiel, can you present yourself?
Good evening, everyone. I am Olaoluwa Ezekiel Dada. I am a second-year medical student from the University of Ibadan, Nigeria. Thank you.
Great. Okay, Mutambo, please, can you present yourself? Mutambo Poster.
Good evening. My name's Mutambo Poster, fifth-year medical student at the Cobalt University, Zambia.
All right, thank you. Next is Bejo Takutsing. Please, can you present yourself?
Greetings, everyone. I'm Takutsing Dormo Bejo, medical student, University of Buea, Cameroon.
All right, welcome. Next is Praise. Please, Praise, can you present yourself?
Praise, medical student from the University of Buea, Cameroon.
All right, Darwin, you have the floor. Please go on. Thank you.
Okay, so good evening once more, everyone. My name is Dawin SICHIMBA. I'm a fifth-year medical student at the Decompressive University School of Medicine in Zambia. I'm also the Director of Operations for the Association of Future African Neurosurgeons. So this evening, we're going to look at surgical management of stroke. So remember, 2 weeks ago, we looked at prevention of stroke, where we also looked at aspects to do with epidemiology and risk factors of stroke. So basically, much of the concentration in this presentation is going to be based on the surgical management of stroke, but in trying to get to that, I also try to explain a few other things as we shall proceed. So that is my outline. We look at the introduction, this cerebral blood flow, rather blood supply, then etiology and pathophysiology, classification, and then we have the right brain versus left brain stroke, assessment and management. We'll look at the main thing of this presentation. So according to the World Health Organization, stroke is a clinical syndrome consisting of rapidly developing clinical signs of focal, all right, or global, in a case of coma, disturbance of cerebral function lasting more than 24 hours or leading to death with no apparent cause other than vascular origin. So in this definition, they have tried to explain the science as well as the criteria that should be used for us to define, or rather to tell whether it is a stroke or it is not a stroke. So if it is due to some other cause, let's say traumatic brain injury, okay, then it is not going to be termed as a stroke. And if it is not more than 24 hours, if these clinical signs of focal disturbance of cerebral function are not lasting more than 24 hours, then it's still not going to be defined as a stroke. All right. Now, in terms of time, if it is less than 24 hours, then it is referred to as a transient ischemic attack. Okay. So a transient ischemic attack basically has similar clinical signs and symptoms, except those clinical signs and symptoms are going to last only for about 24 hours, or rather less than 24 hours, and it's quite reversible. Okay. Although this transient ischemic attack may predispose, or rather it may be people that have had, or rather patients that have had a history of TIA, they are more likely to develop a stroke later on in life. So I think this was also mentioned in the previous presentation, which I've indicated there. We can see that stroke is one of the leading causes of morbidity and mortality worldwide, not just in some parts of the world. And it's even much more in low and middle income countries. So 33% of cases die within 3 weeks, then 48% die within 1 year. So you can see that it is quite something that is that should be looked upon, and to make sure that it is prevented. And even in terms of management, we need to be aware of this particular problem. So the incidence is about 0.2 to 2.5 per thousand of the population per year. Okay, so I've indicated that we can refer to the previous presentation that was done 2 weeks ago on stroke epidemiology, prevention, and risk factors. So just a little about cerebral blood supply. Okay, so remember we have blood coming from we basically, when you look at cerebral blood supply, we basically look at what is called the circle of Willis, okay, and then we have the internal carotid artery and the two internal carotid arteries, and then from there they branch off, where we have the anterior cerebral artery, and then that anterior cerebral artery is connected by the two are connected by the anterior communicating artery, and then you have the middle cerebral artery there. So you can see on the other side here we have the cadaveric section of the circle of Willis. So we have those anterior, we have the anterior cerebral arteries there, and then we have the anterior communicating artery. Then right here we have the carotid artery, the internal carotid artery. So this is the right and this is the left internal carotid artery. Then from there we have the posterior. We have the posterior communicating arteries. By the way, at this point, that's where we have the optic chiasm, which is somewhere around that region. We have the optic chiasm. Then from there we have the posterior, that is the right and left posterior cerebral arteries, and then those behind there we have what is called the basilar artery, which branches off into which is basically a connection of two arteries, that is the two vertebral arteries, or the vertebral artery, and there we have the posterior inferior cerebellar artery. Okay, so the posterior inferior cerebellar arteries, they join the vertebral arteries. Then those two vertebral arteries, that is the left and the right, they join together to form the basilar artery, and then the circle goes up to form that circle of Willis. So basically, when we look at blood supply, like I mentioned, we are looking at this simple structure there, which is called the circle of Willis, and then we have branches from that circle of Willis that are supplying different parts of the brain, or rather of the cerebrum. So this is also just another diagram. Maybe it's not so clear, especially the labels, also just showing the blood supply to the cerebrum. So now let's look at the etiology and pathophysiology. So now when we look at the brain is an organ which is quite sensitive, and it requires a continuous supply of both glucose and oxygen for its metabolism of the neurons. Okay, so for the neurons to function, there's a need for continuous blood supply, which is now this blood supply is what is going to provide the brain with oxygen and glucose. So that is for metabolism. Now, whenever there's interruption to this blood flow, it is going to lead to some alterations. Okay. So now, what is going to happen is that there's going to be a cut, or rather reduced oxygen supply as well as glucose supply, and that is going to cause an alteration in neurological metabolism. Within 30 seconds, we are going to see that alteration, and within about 2 minutes, we're going to see a cessation. Okay, so metabolism is going to cease, is going to stop within about 2 minutes. Then cell death is going to occur in about 15 minutes. So after there's that interruption, especially if there's a total cut of blood supply to the brain, we expect that within about 5 minutes, we're going to see that the cells are going to begin to die. So it is very important whenever we receive a patient with stroke, while we suspect stroke, it's very important to make sure that we maintain blood flow to the brain in order for us to prevent further damage, as we shall discuss later on. Now, the major cause, okay, as we shall look at the classification, the major cause is atherosclerosis, all right? And this can lead to thrombus formation as well as embolism. So let's look at some, this diagram shows some of the areas, rather the commonest areas which are affected by this thrombus, okay? So we shall look at what is called ischemic stroke later on, but these are the two types of ischemic stroke, where we have thrombus formation as well as embolism, and then that can cause a stroke. But those are the main areas where we can have the thrombus or the emboli lodging. Now, further on, or rather, as we go ahead, we see what is called the border zone, or what is called the penumbra. I think this was also defined in the previous presentation. So the penumbra is simply an area around the ischemia core, all right? So there's that area which is most affected, where we are saying that the cells are even dead, the neurons are dying actually. And then around that particular area where the cells are already dead, we find that there is an area where that cell injury is actually even reversible. So the earlier we treat, or rather we manage these patients, the more likely we find that we're going to be able to reverse that cell injury in this region called the penumbra. Okay, so in that region called the penumbra, there's just reduced blood supply. There's not really a total cut of blood supply, and then in this case, ischemia is potentially reversible if the ischemia cascade is timely interrupted, usually within about 3 hours. So whenever we receive a patient where we suspect a stroke, we make sure that we manage those patients, or we treat those patients, or rather we cut that ischemia cascade within about 3 hours, in order for us to preserve this penumbra so that it does not get damaged further. So now let's look at what is called, let's look at the classification. Now, for the purposes of this presentation, I've divided classification in 2 ways, okay? That is classification based on the pathophysiology, and classification based on the time frame, okay? So now, based on pathophysiology, we have what is called ischemic stroke, which accounts for about 80 to 85% of all strokes, okay? And then we also have what is called hemorrhagic stroke, which accounts for about 15 to 20% of all strokes. Now, under ischemic stroke, we have what is called thrombotic stroke and embolic stroke. Now, most of the times, ischemic stroke is by far caused by thrombosis, all right? So now, this diagram here, the first diagram here, is showing a situation where we have a thrombus, okay, where there is narrowing of the blood vessel, which is caused by a plaque, okay, a plaque such as that of a fat deposit. So there's fat deposition there, and then there's reduced blood flow, or rather there's stasis, and because of stasis, we find that there's going to be clotting of blood, okay? So there's hemostasis there, and then blood begins to clot at that region. So once that happens, we find that distally, or rather distal to this clot, we find that there's going to be reduced blood supply, or there's going to be a total cut of blood supply, and the area distal to this region is going to die. Now, of course, we find that the area that is most distal to the clot is going to die faster than the areas that are more proximal to this region. Then in the second diagram here, we have what is called an embolic stroke. Okay, so embolic stroke in this case, we find that it could be maybe a dislodge from a thrombus. Okay, maybe there's a thrombus somewhere. Let's say, for example, like in the case of DVT, deep vein thrombosis. Okay, and then it dislodges, and then it finds itself in the cerebral vasculature. Okay, so in that case, we still find that it can cause a stroke. All right. There are other cases. It could be any other plaque that is circulating through the cerebral vasculature, such as that of that of fat, can also cause an embolic stroke. Okay. Then hemorrhagic stroke. Okay. So let's look at this diagram here. Represents an hemorrhagic stroke where there's rupture of a blood vessel. All right. Now, when there's rupture of a blood vessel here, we find that first of all, there's going to be reduced blood supply to the areas that are distal to this injured blood vessel. All right. Other than that, because there's seeping of blood either into the brain tissue or around the brain tissue in cases where we look at. Remember, this hemorrhagic stroke, it can either be intracerebral or it can be subarachnoid hemorrhage. Okay, so in the case of intracerebral hemorrhage, we see that this blood is actually going into the brain tissue itself. Or in the case of subarachnoid hemorrhage, we see that blood is going in the space between the pia mater and the arachnoid mater. So this diagram is also representing the types of stroke that I've already explained here. Okay, so we have thrombotic stroke and embolic stroke, and then here we have cerebral hemorrhage. Okay, so this is also just a diagrammatic representation of what I'm just from explaining. So remember, I mentioned that stroke, we have primary ischemic stroke, and we also have primary hemorrhagic stroke. So ischemic stroke accounts for about 80 to 85%. Then hemorrhagic stroke accounts for about 15 to 20% of all strokes. Then under ischemic stroke, we have thrombotic stroke, which accounts for 50% of all strokes. And then embolic stroke accounts for about 30% of all strokes. Then, like I mentioned, the total for hemorrhagic stroke accounts for about 15 to 20%. Now, under hemorrhagic stroke, we have intracerebral stroke, hemorrhage, okay, where we have about approximately 15, and then subarachnoid hemorrhage, we have about 5% of all strokes, okay. So intracerebral stroke is more common than subarachnoid hemorrhage. Okay? So this diagram is also simply showing the differences between ischemic stroke and hemorrhagic stroke. All right. So it's also another diagram showing the two differences radiologically. So we can see that in terms of radiology, you can see that in the case of ischemic stroke, it's the region, like in this case, this is an ischemic stroke due to occlusion of the right middle cerebral artery. Okay, so we can see that there's a dark region there around in that region there. Okay, so we should see the difference. In the case of ischemic stroke, it is dark, but in the case of hemorrhagic stroke, it's quite light. Okay, those are the differences when you have MRI when you have MRI. Okay, okay. So based on time, whether time frame, we can have what is called early hyperacute stroke, which is one where if a patient presents within 6 hours, then we can call it as an early hyperacute stroke. Then between 6 to 24 hours, or rather 6 to 24 hours, that is a late hyperacute stroke. Then acute stroke, the patient presents within 1 to 7 days, that is acute stroke. Then subacute, it's 1 to 3 weeks, then more than 3 weeks, we have chronic stroke. So even in terms of management, the management of this patient is going to depend on the type of stroke in terms of pathophysiology as well as in terms of time at presentation. Okay. So because, for example, if a patient presents or rather comes after 3 weeks, you're not going to manage them the same way you'd manage the patient that presented within 6 to 24 hours. So it's going to be different. Okay, so let's look at what is called right brain versus left brain stroke. Now, generally, we should know that the right side of the brain controls the left side of the body, and the left side of the brain controls the right side of the body. So, because of that decussation of the neurons. So now, in the case of right brain injury, okay, right stroke rather, we can see that there is paralyzed left side. The left side is paralyzed, and then we can also find a special perceptual deficit, okay, as well as a quick impulsive behavior and also memory deficit. Okay, so when we see, especially the more apparent one, the one that is more apparent is the hemiparesis. Okay, so if we have left-sided hemiparesis or hemiplegia, then we most likely have a right-sided brain injury, or rather a right-sided brain stroke. Okay, then when we have a left brain injury, most of the times we find that patients are going to present with a right-sided stroke, or rather hemiparesis or hemiplegia. Okay, so that is one thing that is quite distinctive. Of course, patients may present in different ways depending on which specific area of the brain that has been affected. But generally, we see these signs in these patients. Okay, so we should be able to look out and be able to clinically tell which side of the brain is affected, especially in cases where we are in resource-restricted centers, where most of the times we find that maybe CT scan or MRI are not even available. But if we can have that idea, it's going to help us a lot. Okay, so excuse me. Let's look at assessment, or the assessment findings. By the way, what are the goals of this assessment? But this assessment is including history, examination, general examination, as well as neurological examination. Okay. Now, the goals of assessment before we can go to other things, or rather other investigations, is to be able to tell. We need to ask ourselves the question: is this a stroke? When we receive a patient, we ask ourselves, is this a stroke? Okay. And then if it is a stroke, when did it happen? Okay. Because we're going to tell whether it is early hyperacute, late hyperacute, acute, subacute, and chronic. All right. And then we need to also tell why did it happen? Okay. Where we need to find out what could have been the risk factors in this patient. And does the patient have a history of maybe diabetes, heart disease, or maybe something like maybe hypertension? Okay, what could have made this patient to develop this stroke? Okay, so when we have such ideas, we're going to be able to tell. So now, what are some of the assessment findings? One, we're going to find that the Glasgow-Coma scale, the GCS, is going to be reduced. Okay, and then we're also going to have weakness, numbness, as well as paralysis. Okay, then we can have speech or visual disturbances, or even both. Okay, severe headache, reduced or increased heart rate could be some of the findings in this patient. Then respiratory distress, especially if there's cerebral edema and so on. Okay, then we can also find an echopupils in this particular patient. Other assessment findings, we can find that these patients may be having hypertension. They can have facial dropping, or rather drooping on the affected side. Okay. Then we also have difficult swallowing, seizures, bladder and bowel incontinence, nausea and vomiting, and vertigo. Those are some of the assessment findings in these patients. Once we take the history, we do the examination, general examination, as well as a neurological examination, we're going to find some of these findings. Okay. Now, this is a simple tool that should even help communities, okay? Rather people in the community to help people that are close to them to tell if people that are close to them have a stroke or not, okay? So it is called, the mnemonic is FAST, okay? Where the F is for face, okay? So we ask the patient to smile, okay? So if one side of the face is drooping, then we see that we can suspect that the patient has a stroke. Then we look at the arms. If one arm is weak, then we can also suspect. Then speech. If the patient cannot speak properly, has a flared speech, and so on, then we can also suspect a stroke. Now, like I mentioned, this is very important, especially for communities, people in the community, because they are the ones that will bring their close relatives or people that are close to them to the health center. So time is very important. Remember, the earlier we manage these patients, the better. Remember, I earlier mentioned the penumbra, where there's which is the region of reversible ischemia. Okay, so if these people bring the patients to the health centers as early as possible, then we find that we'll be able to help the patients in a better way. Okay, so let's look at imaging. So when you look at an enhanced CT, it has been used for quite some time. It's something that has been helpful. But of course, there are other more improved techniques that can be used. So when you look at an enhanced CT, one, it is quite quick. Okay, it is quite quick. We can get the patient, take them for CT, and do the CT as quickly as possible. And then it also detects early signs of stroke and helps to rule out hemorrhage. So we can be able to tell whether it is hemorrhage or it is just some ischemia that is occurring. So we can see that it is able to show us both the core, okay, the ischemia core, as well as the penumbra, okay, like we can see on that diagram. Then we also have CT angiography. So in this case, we are able to see where there is an intravascular thrombi, okay. So this is very important, and especially for us to definitively manage these patients, especially surgically, we say that we'll be able to tell where exactly to go, or rather also to plan the best surgical techniques to use for these patients. Then we have CT perfusion imaging, okay, which can demonstrate salvageable tissue, okay. Like I mentioned, when you look at the penumbra, this is where we have salvageable tissue, or rather a region where there's reversible ischemia, okay. So this CT diffusion imaging can show that penumbra as well, rather can show where there's a region, there are those neurons that can be reversed, okay. Then we also have MRI, okay. So it can also detect acute infarct on conventional MRI imaging, okay. Now we also have what is called the diffuse weight MRI. So this one is more sensitive compared to the conventional MRI imaging, okay, and it can detect the hyperacute ischemia. Remember, I talked about hyperacute, which can either be early and late hyperacute ischemia, okay. So it becomes abnormal within 30 minutes. Remember, we mentioned that early hyperacute is within about 3 hours. In about 6 hours. So for this one, it begins to show abnormal findings within 30 minutes after injury. So it is quite accurate, and it can show those, okay. And it can distinguish between old and new stroke. So if we have some old stroke and the new stroke, we see that it can still distinguish, because the old stroke is going to appear quite bright, and the new stroke is going to appear quite low in terms of intensity, okay. And then it can also detect irreversible infarcted tissue, okay. So in other words, it can show us the core ischemic center, or the core, the ischemia core, okay. So now let's look at this example. So in this example, you can see that we have a massive right medial cerebral artery territory infarct. So in this case, there was ischemia, or rather there was blockage of the middle cerebral artery, okay, which caused that infarction or that ischemia, okay. And then there's also a midline shift, because the midline it should be somewhere there, but we can see that there's a midline shift, and there's that region of ischemia. Then this diagram here also shows a massive left middle cerebral artery territory infarct in a 52-year-old male smoker who is also an alcoholic, non-diabetic, and hypertensive. Okay, so in this patient, the initial GCS was 12, where the eye response was 3, the verbal was 3, and the motor was 6. Okay, and then this patient also presented with left hemiplegia. Remember, we talked about the right-sided right brain injury and the left brain injury. Now, this patient, the symptoms worsened with time. Okay, so the patient began to worsen symptomatically. Okay, so we can see that region of ischemia. Now, in terms of management, I was supposed to include some images also for hemorrhagic stroke, but we shall see some images as we go later on, especially when we reach the management part. So in terms of management, remember we can have medical management and surgical management as well as nursing management. But for purposes of this presentation, I'll draw much on the surgical management. But just a brief on medical management. First, we need to support, okay, we need to offer supportive management to these patients. We have to make sure that the airways are patent, the temperature is appropriate, appropriate blood pressure, okay? So blood pressure should not be increased. There shouldn't be hypertension. Again, there shouldn't be hypotension, because these two, hypertension or hypotension, are signs of poor prognosis. Then blood glucose, again, if there is hypoglycemia or hyperglycemia, there are also signs of poor prognosis. Then cardiac assessment as well. It's very important for us to assess cardiac function. Then we need to give thrombolysis, okay, either intravenously or intraarterial, okay, and platelet drugs, anticoagulant drugs, hemodiazation, vasodilators, induced hypertension, and so on. Okay, then also neuroprotective agents may also be given. So that is just briefly on medical management of stroke. Now let's look at surgical management of stroke, or the surgical interventions, which is our main area, and then from there will probably be done. Okay, so now what are the goals of surgical management? The goals of surgical management, one is to combat life-threatening raised intracranial pressure. Okay, now in this case, most of the times there's need to do decompressive hemicranectomy, as we shall see further. Okay, then we may also need to divert intraventricular contents, that either blood or CSF, in the case where there is hydrocephalus, all right, where we do what is called external ventricular drainage, as we shall discuss later on as well. Then we can also do endoscopic or craniotomy for evacuation of intracerebral hemorrhage, or rather hematoma. And then you can also clip, wrap, or coil aneurysm to prevent a rebleed. And then you can also have excision of arteriovenous malformations. So basically, those are the goals. Now let's look at these methods. Now we should understand that large cortical infarcts are usually associated with brain swelling or cerebral edema. Okay, because remember, if there is interruption to metabolism, all right, then we're going to find that there's going to be imbalance in the sodium potassium ATPase, and then because of that, we see that there's going to be a lot of water going into the cells of the brain, and that is going to cause swelling. All right. Now, what are the indications for surgery in stroke? Indications: one, patient age less than 60 years old. All right. So we don't want to go for those that are too old, because it's going to be a contraindication. Those that are too old, there are quite higher risks in carrying out this. Okay. Then clinical assessment. Okay, severe middle cerebral artery infarct. Okay, where the NIHSS is greater than 15. Then 4 of consciousness level to drowse. That is, if we have the GCS which is less than or equal to 9. Okay, that is especially when we consider the eye response and the motor. The GCS is less than or equal to 9, then it is an indication for surgery. Then signs on CT of an infarct of at least 50% of the middle cerebral artery territory. Okay, so remember the images that I showed earlier, where we had middle cerebral artery territory infarct. Okay, if the area that is damaged is at least 50%, then we may need to consider surgery. Then referral within 24 hours of stroke onset. Surgery no later than 48 hours after stroke onset. Okay, so most of the times, the earlier the better. The earlier we do the surgery, the better for the patient. The better prognosis we expect. Now, let's look at surgery in ischemic stroke. Okay, so the choice of surgical technique that we choose is dependent on what type of stroke it is. If it is ischemic stroke or if it is hemorrhagic stroke. All right. So this diagram is showing a pre-op images and post-op images. Now this was just hemicranectomy. Okay, without just simply to relieve the pressure. Okay, so it is decompressive cranectomy. All right. Now, when we look at ischemic stroke intervention, surgical intervention, we can have endovascular as well as we can have endovascular. We can also have carotid artery endarterectomy. We can also have extracranial, intracranial bypass surgery. That is under ischemic stroke. All right. So let's look at this. When we have ischemic stroke, one of the options that we can choose, like I mentioned, under endovascular interventions, is what is called angioplasty and stenting. So in the case of angioplasty and stenting, they may be a bit different, or they may be two different procedures, or they can be done at the same time, okay, or immediately after the other is done. So angioplasty is where there's sort of a catheter that is inserted into the blood vessel that is affected, the artery that is affected, okay. So let's say, for example, if we talk of a middle cerebral artery, if we see that there is a plaque, and then we can insert a catheter which has a balloon, and then that balloon is inflated so that the blood vessel is reopened. So the blood vessel was occluded. So we take that catheter and the balloon just where the plaque is, and then we inflate the balloon so that we open the stenotic vessel. Okay. Now stenting, like I mentioned, they can be done almost concurrently, just after or during angioplasty. So in this case, we have this metallic material that is inserted in order to keep the blood vessel open. Okay, so that is a stent in this case, as we can see on the diagram. So they can be done just after angioplasty. Okay, then another endovascular intervention that we can do under when we have ischemic stroke is what is called mechanical clot disruption and removal. Now, in this case, we can see that there is insertion of what is called a microcatheter, which traverses the thrombus. So we have a thrombus there, all right? We have a thrombus, and then we insert a microcatheter, which traverses through the thrombus, and then after that, we the first looks of the message retriever, are delivered distal to the occlusion site. Okay, so you have that missile retriever, which is delivered through this microcatheter distal to the occlusion site. Okay, then this missile retriever is put back in order for it to be in contact with the thrombus, and then additional loops are also delivered within the thrombus. So you can see that there's that loop, and then once it is put back, additional retrievers are also delivered in the same in the thrombus there, and then it is retrieved or it is put back. Okay. Now at the end, just at the end of the microcatheter, we see that there is a suction, more like a suction tube. So once the thrombus has been put, that thrombus is going to be suctioned through that tube and will be done. So this is just sort of some statistics on the success rate of this procedure. Then another endovascular intervention that can be done is what is called clot extraction. Now, in clot extraction, you can see it's a bit different from, it's not so different from the mechanical clot disruption and removal. They are almost the same. Okay, so equally, you can see that there's a short device that is that retrieves and removes clots more safely. Okay, so it is inserted and then it is used to remove those clots. All right, so that is another endovascular intervention. So number two, under ischemic stroke surgical interventions, we have what is called carotid endarterectomy. Okay, so in this case, it's just a situation where we make an incision. Okay, we make an incision and then we open the carotid artery. Now, in this case, if we suspect signs of reduced blood flow, okay, or probably we've seen maybe on MRI or other imaging modalities, we see that there's a plaque that is in the carotid artery. Okay, so an incision is made just along the carotid artery, the internal carotid artery. All right, and then a shunt. Most of the times, there's need to put a shunt so that we maintain continuous blood flow to the brain. And then after the shunt is inserted, we remove that plaque safely. Okay, so there's a video that I've attached right there. I'll probably share the slides so that that video can be accessed. It's quite an interesting procedure that can be done, and it's quite helpful. It has quite some good responses, or rather we have good responses sometimes depending on the situation. Then we also have what is called extracranial intracranial bypass. So this is simply a situation where we get maybe a blood vessel. Most of the times we get a venous graft, okay, from somewhere else in the body, and then it is inserted in the brain, or rather in the cerebrum, cerebral vasculature, in order for us to bypass that region where there's a plaque. Okay. Now, most of the time, this is done in a situation where the occlusion site is not easily accessible. Okay. So if the occlusion site is not easily accessible, or we suspect that by accessing that particular region, we may end up damaging other important areas, then it may be important to consider ACIC bypass surgery. Then surgery in ischemic stroke. All right. So surgery in ischemic stroke. Remember, we mentioned we can hemorrhagic stroke. We can either have intracerebral hemorrhage or subarachnoid hemorrhage. Okay. So most of the times, what is done is decompressive craniotomy. Sometimes it may be without hematoma evacuation. We just want to decompress. Okay. Especially most of the times we find that there is cerebral edema, and there's going to be increased intracranial pressure. So in order for us to relieve that increased intracranial pressure, there may be need of doing this decompressive hemicranectomy. Okay. Then most of the times in the case of although I've not indicated here. By the way, before I go to that, the hematoma can also be evacuated through a neuroendoscope. Okay, so after we do that decompressive hemicranectomy, we may also decide to evacuate the hematoma. Okay, now in the case of subarachnoid hemorrhage, okay, now most of the time subarachnoid hemorrhage is caused by aneurysms, okay, cerebral aneurysm. Now, in this case, what is usually done is what is called clipping and coiling of the aneurysm, okay. I didn't show the images here, unfortunately, but remember when you look at the structure of the aneurysm, it has that neck-like structure, okay, or rather portion. So on that same neck-like portion is where you put a clip, okay, so that blood is not going into that clip. And because if there's blood in that aneurysm, then there's even going to be stashes of blood in that aneurysm, and eventually there's going to be clotting, okay. And what we achieve is that blood is no longer going to be going into that aneurysm, okay. Now that is quite helpful, but sometimes there may also be need to insert, just like in this case. Let me take you back to this. Okay, sometimes we also do stenting. Okay, we can also put a stent in the case of cerebral aneurysm. Now imagine the way we have this blood vessel here. Okay, so like apologies, I didn't include that diagram. The way we have this blood vessel here, but imagine there's an aneurysm somewhere here. Okay, and then we put a stent. So this stent is going to be more like diverting the blood. Instead of that blood going into the aneurysm, it's just going to be going straight without going to the aneurysm. And in that case, it is going to reduce on pressure in that aneurysm and reduce the risk of rupture of the aneurysm. Then sometimes in the case where we have intraventricular, okay, intraventricular hemorrhage with acute hydrocephalus and ventricular hemorrhage, we can also put insert a drainage into the ventricles, okay, more like a shunt, in order to reduce the intracranial pressure. Now, these diagrams here are simply showing the technique, or rather the process of decompressive hemicranectomy. So first of all, there's infiltration with xylocaine, okay? So that is just an anesthetic agent, and then of course you have to make sure that you sterilize that region, and then you proceed. So an incision is made, hemostasis is achieved by clipping the blood vessels, and then we flap we reflect the flap, okay? Then from there, there's going to be bone flap elevation. We elevate the bone flap so that we expose the meninges. Okay. So after the meninges are exposed, we remove we inside the meninges. We're going to access the brain, and also if we need to evacuate the hemorrhage, or rather the hematoma, we evacuate it, and then we put what is called a Angioplasty and then close the wound. Then we're done with it, the decompressive hemicranectomy. Now, what are the signs of poor prognosis? Rather, what are some of the factors that can show us poor prognosis? So one, if there's accompanying fever. Two, if there's hypertension or severe hypertension, like I already mentioned. Low oxygen saturation. Remember, the brain is quite sensitive to hypoxia. Okay, so if there's reduced blood supply and reduced oxygen supply to the brain, then we have quite some poor prognosis. Hyperglycemia or hypoglycemia, they're also poor prognostic factors. Remember, when you have hyperglycemia, it means that it is going to increase. Hyperglycemia may increase the cerebral edema. Okay, and then remember, these neurons, they depend on glucose. Again, if we have reduced glucose, metabolism is going to be altered. Okay, then total anterior circulation stroke. okay, where we have about, or rather more than 50% of, especially in the case of middle cerebral artery occlusion. So if about, if at least 50% of the middle cerebral artery territory is damaged, then we find that there's going to be quite some poor prognosis. Then pontine hemorrhage, this is quite dangerous. Low GCS, especially at presentation, then we find that it is also going to give us a poor prognosis. Heart failure and severity of the hemiparesis, those are poor prognostic factors. Okay. So in conclusion, the most important thing in management of stroke is prevention. Okay, like we discussed in the previous presentation, it is best to prevent. Okay, prevention is better than cure. So in patients that are at high risk of stroke, okay, let's say for example those with underlying cardiac disease, hypertension, diabetes, high cholesterol levels, and so on. Those we need to make sure that we prevent. Okay. Then treatment of underlying predisposing conditions is also very important. Surgical management should be timely. So the earlier the better for these patients. So that marks the end of my presentation. Thank you very much.
Thank you very much, Dawin, for this wonderful presentation. Thank you for the presentation. So if anybody has a remark or a question, the person can indicate by raising his hand, and I'm going to pass the floor to the person. But in the meantime, I would like Dr. Marvin to give us some comments and any remarks he made.
Okay, well, it was a great presentation. He didn't just go to the surgical management, but also went through basics, physiopathology, medical management. I think talking about surgical management, first the goal should be stepwise. Like, you need to know that the surgical management is not just to treat the stroke itself, but also focuses on the primary cause, treat the complications, and also prevent recurrence of the stroke. So when you do that classification, you can output various procedures addressing a specific situation. So I think some of the surgical procedures wasn't mentioned. For instance, surgical embolectomy, because in some cases of ischemic stroke, when you have failure of endovascular revascularization, you have to go for surgical embolectomy, mainly when you have big cerebral vessels like the supracrinoid, internal carotid artery occlusion, or the first or the second segment of the middle cerebral artery, or even the first or second segment of the anterior cerebral artery. We do either a mini craniotomy or pterional craniotomy, get to the vessel and do an arteriotomy to remove the clot. Also, if you are treating ischemic hemorrhagic stroke secondary to arteriovenous malformation, you can do embolization. So he didn't mention that. I think it's a big topic, and to touch everything, you need to know the goal of your treatment. For instance, to prevent recurrence, you do bypass surgery, because bypass surgery, there are not much studies proving with enough evidence to support bypass surgery to treat the stroke. But for prevention, there are many studies with evidence of reduced recurrence, like in patients with carotid artery disease, occlusion disease, or moya disease. We do a bypass, external carotid internal carotid artery by doing an anastomosis of the superficial temporal artery and the medial cerebral artery, for instance. Or in some cases of vertebropasaular system insufficiency, you can do a posterior bypass with the occipital artery and the inferior, the pica, posterior inferior cerebellar artery. So I think by doing that, you have presented most of the surgical intervention, but again, a great presentation.
Thank you so much, Dr. Marvin. Always having very nice remarks. All right, there's a comment about Dr. Ulrich gave us some comments. Dr. Uke, sorry, gave us some comments. So, Dr. Uke, you can take the floor and voice out what you wrote in the comment section, please, if possible.
Okay, okay, thank you very much. I firstly thought the traffic will be very full, so I won't be able to speak start to write. Thank you very much for the presentation. It's a great presentation. Thanks a lot. For the same, there are some certain things that we need to add to it. I was talking about the hemicranectomy that you spoke about. Usually, why do we do this hemicranectomy and we don't touch the hematoma? About the image that you showed. The thing is that it's not all the hematoma that we evacuate when you are having this kind of patient. So it's recommend that we carry on just the hemicranectomy and we leave the hematoma in place, because this hematoma is deep located. Is deep located inside the brain. Is located at the level of the basal ganglia, at the level of internal capsule, the straight nucleus and nuclei, and those structures that are very, very important for the brain function. So the experience has shown that while you are trying, while the surgeon is trying to manage removing this hematoma, it has caused more damage to the patient. So for now, I think what has been done is just do the decompressive craniotomy to release the brain. So you leave the hematoma, you don't touch it. You don't want to go inside there to go and search for any hematoma. Just leave the patient like that. Since the craniotomy is done, the hematoma, the brain will find a place to shift a little bit. The edema will reduce. The hydrocephalus also will reduce, and with time, the hematoma will subside. With time, it will be dissolved. That's what I want to add to what you said. The second thing is about the criteria. The criteria that we use to when we are talking about doing carry on a surgical procedure with this patient with ischemic or hemorrhagic stroke. So when do we do surgery, or when do we send the patient for endovascular procedures? If the presenter can come back with some ideas about that, it will be very nice for the presentation. So these are the two things that I want to add. Though it's a great presentation. It's very nice. Thank you very much.
Thank you so much, Dr. Uke, for the wonderful remarks and the comments. Thank you so much. So we don't know, thank you. Is somebody in the house, the panel, ready to take the presentation Dr. Uke speaking about, like trying to give the criteria for surgical management of a stroke? Maybe do a presentation on it. Anybody? What about Bejo? Will you be able to do that next week?
Not really. Because
it will be very nice. It's a huge topic. It's very important. The criteria are known, and we can discuss about it next time, as you said. It will be very nice.
Anyway, I'm going to discuss in inbox with the various people to try to find if somebody can do the presentation. Thank you so much, Dr. Uke, for the comment. Is there somebody who has a comment, any remark, any question? Okay, Bejo, your hand is raised. Go on.
Okay, thank you very much, Darwin, for the presentation. It was really great. I really enjoyed every bit of it. Okay, before I mention my comments, I also would love to ask a question to Dr. Hughes, because you said that if you do a decompressive hemicranectomy and there's a hematoma in the level of the basal ganglia, then you leave the hematoma there. Then I don't understand then, what is the reason of you doing the hemicranectomy? Because I was thinking that the main aim is to kind of going out and look for a way to reduce the hematoma and probably the edema. Then why they need to do it if actually at the end of it you see the hematoma then please?
That's a very nice question. Though I think I have the answer, but Dr. You can go on and or Darwin can reply that. I don't know.
Okay, to try and reply to that question. So remember when we have hematoma, okay, intracerebral hematoma, one of the complications that are going to be there is that there's going to be cerebral edema.
Sorry,
right?
I didn't hear the comment.
Yes.
Okay, so what Bejo was saying is that given that because you said that if for example the hematoma is located deep in the brain, you just do a craniotomy just to kind of decrease the pressure. So he was not understanding why we do the craniotomy without going to look for the hematoma, because we don't look for hematoma if it's deeply located. As you said, it's going to cause more damage to the patient than good. So he was trying to understand the why. Maybe we get the explanation.
That's a very nice question. That is a very important to know. Thank you very much for asking. So the reason why is very simple. First of all, the reason bounds to the etiology of this hematoma. Most time when we are dealing with a patient that is having hypertension, is a hypertensive patient, this bleeding, this hematoma is not coming from aneurysm. This bleeding is due to the high cranial pressure. In this case, we don't bother to go into looking for this hematoma. It's when you carry on some etiological research. I mean, complementary exam like arteriography, and you find out that in this patient, this hematoma is a bleeding from aneurysm, for example. Then you got your etiology, and then you go to treat this etiology. While going to treat this etiology, at the same time you can evacuate the hematoma. But in case when there is you don't find any other etiology that can explain this hematoma, and the hematoma is just due to a burst of a vascular wall due to this patient having 20 or 50 or 20 years of high blood pressure and is not well treated and all those things, then there's nothing to go and treat over there. You leave it that way, it will subside. I don't know if you get my point.
Yes. Thank you very much.
That's the thing. So that is what is done so far. You don't is when you to treat the etiology of this hematoma, you will go into you will approach subfrontal approach. You go down in some subdural area to clip this aneurysm, and at the same time you can I'm saying you can because at times you cannot. You can try to see if it's possible to evacuate the hematoma. The evacuation of the hematoma is not 100% what we are going. What is not the main reason why we are doing this surgery. No, the main reason why we are doing surgery. The first reason is to release the brain, to allow the brain, which has swelled already, to find space. The second reason it may be to treat the cause, and the cause that we treat are well known, like aneurysm and vascular malformations. But if that has not been found while you are carrying on this arteriography and all that, you define anything, then you don't go into with that. Just adjust your craniotomy and you leave the patient alone. He will wake up. He will wake up and he'll be fine.
Thank you very much, Dr.
I've done I've assisted and I've done three already, and they are fine. They wake up, they are fine with this hematoma inside their brain. And after a checkup of, after 6 months of checkup, the hematoma will reduce. You do CT scan again after 6 months, and when you see the hematoma is reducing, so you are calling the patient to continue. They're feeling that the post-operative things that they are being asked to be done and all those things, and the treatment, he'll be fine. He'll be fine.
Right. Thank you very much,
Thank you.
Dr. Hugh. Okay, Dr. Marvin has his hand raised. Please, Dr. Marvin, you have the floor.
Okay. Well, with Dr. Hughes' permission, I would like to add something to what he have said already. The thing is, when you go for surgery, the first thing is not to damage the brain more. So if you have a deep hematoma, you don't need to go and remove that hematoma, because doing that, you damage the brain. The latest recommendation from what I have read, latest recommendations on standard craniotomy hematoma evacuation are those of the American Heart Association and American Society of Anesthesiologists of 2015. Well, you can remove the clots if they are based on the volume, if it is greater than 30 milliliters, and also if it is within 1 centimeter of cortical surface, because it's easily accessible. You can remove it without further damaging the brain. Okay, so that's what I wanted to add.
All right, thank you so much for all your contribution. Thank you very much for your
Yeah, that's a nice contribution, and you are working already on the next presentation.
Indeed.
These are the criteria that we use to know it's part of the criteria that we use to know which patient is candidate for removing the hematoma, and on which one is not candidate. And you're right, absolutely right. And that's what I was saying. Don't need to go and remove the hematoma by force, and it's not mandatory. There are some criteria that we use to do that, and is this the criteria is called, I think, as you said, is American Association intracranial hematoma. I think that's how you call it. They call it, and is how you to age, the volume of the hematoma, and as you just say now, and the edema, and there are some criteria that we use, and we mark them to have a point. And next time maybe as you just say it now, next time someone can present that for us.
Yeah, you are going to look for someone to do that. Okay, thank you very much for everybody for coming. Thank you very much for your time and wonderful presentation once more, Dawin. We are proud of you as usual. So yes, somebody has a question.
Yeah, it's a further question.
Okay, go on.
Yes, at the beginning of the presentation, Dawin said that the ischemic cascade, that to prevent an irreversible brain damage, normally you're supposed to reverse that cascade within 3 hours to prevent an irreversible damage. But now, since but now, why is it that usually this thrombolytic therapy you can do it if it's possible within 6 hours, or even still in the presentation, Dawin said that you can do surgery no later than 48 hours. So it's like I kind of assume that if the patient comes like 24 hours later on, that is if I according to what I just mentioned about the ischemic cascade, because I said that by then the irreversible brain damage has already occurred. Because one of the aim of the surgery is to kind of prevent irreversible brain damage and probably treat the etiology in case it is an ischemic etiology. So I'm kind of a bit confused.
All right, Dawin, can you bring an element of response to that question? if you have any.
Okay. So to try and answer that question, I think what I mentioned was on the penumbra. One of the things that I talked about. Remember, we said that in terms of when we have ischemia, we have the core ischemic area, and we also have the area surrounding that core ischemia, which is called the penumbra. Now, that penumbra, it is having a tissue that where there is ischemia, but it can be reversed if management is done within the shortest period of time, in about 3 hours, right? So the goal in this case is to make sure that when we receive a patient, we should know that there's that area, okay, and it is very important for us to preserve it, okay, to salvage it, okay. So we need to make sure that that area does not get permanently damaged, because if it attains permanent damage, then there are going to be more complications. Or rather, imagine, for example, if it is let's say for example, like right meningeal cerebral artery territory infarct, okay, then if that area, that infarct is less than 50%, okay, is the one which is affected. And if together with the penumbra, it is going up to more than 50%, okay. So if we don't manage these patients as early as possible, what is going to happen is that even that penumbra, which is not yet permanently damaged, is going to be damaged. And in that case, we're going to have more than 50% of the right middle cerebral artery territory being damaged. Okay, and that is going to be, remember I mentioned that that is one of the poor prognostic factors. So timely management of patients is going to avoid, or rather it's going to prevent further damage of such areas as the penumbra. In the case of hemorrhage, remember when there's hemorrhage, there's also going to be cerebral edema, and cerebral edema further damages the brain tissue. So the earlier we manage these patients, even in terms of surgery, the earlier we manage the patient, the better outcome that is going to be there. Because if we wait longer, so that is why it is important, like I think, is it Dr. Marvin mentioned about the criteria for which patients should go for surgery and what type of surgery exactly to be done. So we need, it's important to be able to decide as early as possible, so that we preserve the part of the brain that can be preserved. So I don't know if I've answered your question. If there's anyone with an addition to that, you can please do so.
Yeah, if you allow me to.
Is your question answered? Okay, doctor, you go on.
Yeah, sorry, I will ask something. You're absolutely right. What is written in the literature, and this patient needs to manage as early as possible. Talking about the ischemic side, the reason why we don't want to, or it's been described that patient there's more brain damage after removing of the clot and all those techniques that you've already described. The thing is that when the clot is removed and the circulation is restarted, there is so-called revascularization injury, revascularization of the brain injury, which is at times more dangerous to the brain, because when that part of the brain that lack blood and oxygen and nutrient, the blood start to flow to that side again. There is this brain this revascularization injury that give more injury to the brain. But today our colleagues of neuroscience are talking about this brain plasticity, and these new techniques, this new knowledge that they're bringing to the neuroscience is a kind of trying to push a little bit forward this discussion, because even if the patient comes very late, there's a chance to give him a chance to treat him and not we cannot say that this patient is because this ischemia is been 72 hours or it's been more than 45 days, so nothing to done again. No, you're absolutely right from what you say, but nowadays the thoughts are going to that side, and some medications are coming up to allow and to encourage surgeons to carry on those techniques that can allow the blood to flow again to those areas, because the brain, some patients, I don't know if I still have those publications. There are some works that have been published, and they've described, they've shown that patients have been operated much later compared to from this penumbra area and this time, and the patient recovered. The patient recovered with time. So they can still do it. You're absolutely right for what you said, but I just want to add that the scientific knowledge has been pushing so far. Yeah, exactly. So
as studies go. Okay, thank you very much for everybody for coming. We are going to stop here today and see you next week. Thank you.